of COPD, its diagnosis and the practical difficulties. At the end of the session, I believe that the participant should be familiar with the definition of COPD, the diagnosis and staging of COPD, and the assessment of severity, pharmacotherapy and stepwise management of stable COPD, management of COPD exacerbations, and the role of domiciliary therapies like long-term oxygen therapy, domiciliary mechanical ventilation, and non-invasive ventilation, and other rehabilitation programs. I'll also like to talk briefly about the role of surgery for treatment of COPD. Most of you would now know that the GOLD guidelines 2017 have also come. However, I'm sticking to the definition which has been made in the 2016 guidelines document. It said it is a common preventable and treatable disease which is characterized by persistent airflow limitation that is usually progressive and associated with enhanced chronic inflammatory response in the airways and the lungs to noxious particles and gases. Exacerbations and comorbidities contribute to the overall severity in individual patients. So, as far as one can see from this definition, that persistent airflow limitation and inflammatory response, progressive disease and comorbidities. These are some of the important points for the diagnosis of COPD. How to really diagnose COPD? For a clinician, the symptoms are important. For example, the presence of cough, sputum and breathlessness, which is progressive. Another important factor is exposure to risk factors like tobacco, smoking, the commonest one. Then of course the occupational exposures to the occupational dusts, and then indoor and outdoor pollution in general. I think we have recently heard about the outdoor pollution in Delhi, and you can imagine how damaging it would be for lungs, you see, especially for disease like COPD. Then of course the diagnosis is confirmed with the help of lung function test, spirometry. But the misdiagnosis is frequent. Many times patients are incorrectly labeled as COPD or asthma. There may be a genuine difficulty in diagnosis because of the overlap of symptoms between COPD and asthma, as well as the lack of awareness of differences between these two diseases. Many times patients of COPD are labeled as having asthma because general people as well as physicians are not commonly aware of the terminology COPD. When to suspect the diagnosis of COPD? Primarily it is suspected from the presence of symptoms of cough, expectoration and dyspnea, as I have already stated. Exposure to risk factors is important. And then of course the history of recurrent exacerbation. Physical signs for the diagnosis are rarely important, you see. They are sometimes become important. There may be presence of wheezing, crepitations and other findings, but in pure cases of emphysema, for example, when patient may complain of breathlessness, signs may be minimal, you see, especially in mild to moderate COPD. One has to consider the presence of alternate diagnoses like asthma. Tuberculosis has been listed here for a new patient who comes with cough and sputum production, although in many situations, especially outside India, that will not commonly listed as one of the differential diagnoses. Similarly, bronchiectasis or other lung diseases like interstitial lung disease, the eosinophilic lung disease, etc. can also be considered in the differential diagnosis. Congestive heart failure is an important differential diagnosis in the beginning in an adult patient who comes with short history of breathlessness. Coronary heart disease again can present with breathlessness. Important complications of COPD include chronic cor pulmonale, respiratory failure, which is common and may be responsible for exacerbations, chest infection similarly, pneumothorax and other associated coronary artery disease and so on. So how to really diagnose or establish the diagnosis of COPD? One has to also exclude other diseases which I have listed earlier and complications which I have just now listed. To establish the diagnosis of COPD, most important of course remains the clinical symptomatology. Chest X-ray is helpful. It may show you hyperinflation of the lungs or the presence of bullae, etc. In some cases, chest X-ray can be reported as normal. In these patients, chest CT scanning may be of particularly help. And then, as I said earlier, the airways obstruction measurement with help of spirometry and bronchodilatory reversibilities makes the differential from asthma and so on. Spirometry is the gold standard for confirmation of diagnosis and assessment of severity. One should measure FVC, FEV1 and FVV1 over FVC ratio. The post bronchodilator FEV1 of less than 80% predicted with FEV1 over FVC ratio of less than 70% indicates the presence of airway obstruction, and the diagnosis of COPD would be established. You see. So what is the role of spirometry in COPD? Well, spirometry, one, as I said, is done to confirm the diagnosis. It is also important to determine the best lung function and to then subsequently follow the lung function. Sometimes to assess the subclinical disease, because patient may complain of cough and the diagnosis may be missed. But if one finds airway obstruction on spirometry, then the diagnosis is practically confirmed. You see. Evaluation of treatment, the role of bronchodilators for that matter, you see, for this the best measure would be with the help of spirometry. It can also be used to predict the outcome of COPD and for intensive monitoring of a patient of COPD. Of course, spirometry is also routinely employed for epidemiological research, for the prevalence studies and risk factors studies, etc. There are several alternate causes which can be confused, and for these conditions, one would need to do alternate investigations like sputum examination whenever tuberculosis is suspected. Chest X-ray is also done to exclude other diseases like tuberculosis and sometimes tumors, and to detect complications like pneumothorax or other pneumonias. And so. Arterial blood gas analysis is important, especially in patients with FEV1 of less than 40%, because it is required to diagnose the presence of respiratory failure, hypoxemia, as well as hypercapnia. Other tests may be required depending on the clinically suspected problem. Once you have diagnosed COPD, how to really stage or characterize or categorize the disease, you see. According to the GOLD assessment, especially for treatment, as I said, there have been some changes in the latest document, but I will go into this, the established categorization. It is categorized into 4 types, the A, B, C, D, and depending upon the 3 parameters, severity of airway obstruction measured with the help of spirometry, the presence of symptoms, and the number of exacerbations. As one can see here, the category A is when the presence of symptoms is mild, the severity of airflow obstruction is also less, and the number of obstruction is also less. So that is a mild to moderate disease, minimal symptoms, few exacerbation. The B category, here you can see the symptoms are severe, but the airflow obstruction as well as the number of exacerbations are few. So this is category B. On the other hand, category C is when the severity of airflow obstruction is significant. The exacerbations are also more, for example, more than 3 to 4 per year. But the symptoms are not very significant. So that is why we put it in category C. While in category D, all the 3 things, the airflow obstruction, the symptoms, as well as the exacerbations or more, you see. So that is the worst type of or most severe type of COPD. How to manage these different categories of COPD? Our objectives here are to prevent the disease progression, the relief of symptoms, improve the exercise tolerance, improve the health status, prevent and treat exacerbations, prevent and treat complications, reduce mortality from COPD, and minimal side effects from treatment. So there are a number of objectives which should be fulfilled with the comprehensive management plan. The basic considerations while deciding treatment are that it is a heterogeneous condition, you see. So all patients should be viewed as individuals. Consider the clinical presentation, history, symptoms, disability, response to drugs, and other factors, you see. So I mean, patients in different categories, B, C, D, and with the presence of different complications or comorbidities need to be treated differently, you see. Stable COPD, I suppose that is one of the important issue. If you really look into the basic premise of pharmacotherapy, then I would say that none of the existing medications for COPD has been shown to modify the long-term decline in lung function. And the evidence, degree of evidence available for this is A. So it is a progressive disease, I suppose. That is one unfortunate thing which we have not been able to really cover, you see, that it keeps on progressing in spite of all pharmacotherapy. Although pharmacotherapy for COPD is used for all conditions, and it is used to decrease symptoms and or complications, but it does not really prevent the progression, you see. What are the bronchodilators which are available? Bronchodilator medication is the central to symptom management. They reduce breathlessness by causing bronchodilation, improve lung function to some extent. The health related quality of life is improved. The patient is able to do better and kind of cope with his daily routine activities. Inhaled therapy is preferred than the oral drugs. And there is a choice between beta-2 agonist, short-acting and long-acting anticholinergic agents, theophylline, or a combination of drugs thereof. So multiple drugs are available as bronchodilators, and these are some of the drugs which are commonly available in this country. The beta agonists include the short-acting beta agonists like salbutamol and terbutaline, and long-acting beta agonists like salmeterol and formoterol. Then we know the anticholinergics, ipratropium and tiotropium. Of course, there are more in the pipeline, and some of them are already available, like indacaterol, glycopyrronium, etc. I'll briefly mention about those things, you see. It has been generally believed, especially in the past, that the predominant parasympathetic tone is there in COPD. So anticholinergic drugs like tiotropium or ipratropium is the first choice, you see. Combination of tiotropium with formoterol is also useful, and tiotropium initially has been shown to reduce the COPD exacerbations and hospitalizations compared to placebo or ipratropium. So tiotropium has remained as the first line of treatment for stable COPD, you see. Other bronchodilators are also available, like PDE4 inhibitors, the oral roflumilast, long and ultra long acting beta agonists. Some of them have already said, the salmeterol and formoterol, and in the recent past other like indacaterol, olodaterol and vilanterol have also become available. Long acting anti-muscarinic agents like glycopyrronium, umeclidinium and aclidinium, etc. They are available, and some of them will be available soon in the Indian market as well, you see. The latest evidence suggests that LABA-LAMA combination is perhaps the best choice, you see, for treatment of COPD. That includes the indacaterol glycopyrronium combination, indacaterol tiotropium combinations, aclidinium and formoterol and others, you see. If you really compare inhalers versus oral, then there is enough evidence now that inhalational route is preferred. One can use either meter dose inhalers or the dry powder inhalers, and some of these patients who cannot take either in this form, then nebulized aerosols are also available. There is evidence to say that the MDIs used with spacer are almost equally effective as the nebulized aerosol, and that so one should prefer MDI with spacers. DPI, the dry powder inhalers, are easier to use but are a bit costlier, and in fact some of these patients with severe disease may not be able to generate that much inspiratory flow to inhale the dry powders, you see. It is important that the patient is instructed regarding the proper use of the inhaler device, because with all inhalers, the technique is the most important component of treatment, you see. Inhaled corticosteroids, unlike in asthma, they are not the first choice. They do not have any appreciable impact on the rate of decline in FEV1, but they can improve survival because they reduce the exacerbations, especially in patients with FEV1 of less than 50%. And the earlier categories which were seen in categories C and D in particular. High dose inhaled corticosteroids with a LABA, long-acting beta agonist, is better than inhaled corticosteroid alone. And current indication is that patients with FEV1 of less than 50% predicted and or experience frequent exacerbations of more than 2 per year, they should be given routinely inhaled corticosteroids. And this was one of the this was a study which shows the difference in mortality between the inhaled corticosteroid group and the placebo group, and you can see here on long-term follow-up for almost several years, 4 years, you see the survival was much better with inhaled corticosteroid group, you see. So what is the initial therapy based on categories? The patient group A, which is the mild group, the first choice is a short-acting muscarinic agents or a short-acting beta agonist, but the alternate choices are also there, which can be employed if necessary. Theophylline is not the first preferred choice, but is available as an alternative, you see. For category B, either a long-acting muscarinic agents like tiotropium or glycopyrronium, with or without LABA, I think the indacaterol in particular has become important, you see. For categories C and D, additionally, we would like to add inhaled corticosteroids, you see. This is a recent study which shows the kind of popularly known as the FLAME study, which has employed indacaterol glycopyrronium combination versus salmeterol fluticasone for COPD management. A 52-week randomized double-blind, double-dummy, non-inferiority trial was done, and it is seen here that the annual rate of moderate to severe exacerbations was lower in the indacaterol glycopyrronium group than in the salmeterol fluticasone group, you see. So that this study practically shows that that inhaled corticosteroids is not the first choice or not the better choice in patients of COPD. The time to first moderate or severe exacerbations was longer in the indacaterol glycopyrronium group than in the salmeterol fluticasone group, you see, as was the time to the first severe exacerbation. So that study shows a significant advantage of using indacaterol glycopyrronium combination over inhaled corticosteroid and beta agonist combinations. I think I have already said that, and What other therapies can be used in patients with COPD, like mucolytics, immunomodulators, antibiotics, respiratory stimulants, antioxidants, and vaccinations can also be used. Talking about management of acute exacerbations, one defines acute exacerbation as acute change in patient's baseline dyspnea, cough, and/or sputum beyond day-to-day variability, which is sufficient to warrant a change in therapy. This can be categorized into level 1, 2, and 3. Of course, acute exacerbations can be infectious as well as non-infectious. Once there is acute exacerbations, then treatment is obviously intensified. One has to use supplemental oxygen, pharmacotherapy as earlier, with the additional use of other drugs like antibiotics and systemic corticosteroids. And some of these patients may need assisted ventilatory support whenever there is a presence of respiratory failure. Oxygen therapy, the main purpose is to maintain saturation of 90%, and it can be delivered either with a nasal cannula or venturi mask. One needs to monitor the blood gases. Arterial blood gas analysis should be done, but monitoring routinely is done with the help of pulse oximetry. It is important to prevent tissue hypoxia, and if CO2 retention occurs in these patients, then acidemia needs to be monitored. If acidemia occurs, then of course mechanical ventilation is also considered. The use of parenteral methylxanthines. Parenteral administration is widely practiced for acute exacerbations. I think intravenous aminophylline has been a very traditional method in this country in general. It shows modest and inconsistent improvement in lung function and clinical endpoints. But there is significant increase in adverse effects, nausea, vomiting, sometimes abdominal, and even convulsions, etc. can occur when the dose is increased. So it is better to avoid the parenteral methylxanthines. However, they are very popular in peripheral setups in particular. They are cheap and widely available, and they may provide extra bronchodilation if used cautiously as an added adjunct to other therapies. Systemic corticosteroids are required for acute exacerbation, short courses. They decrease the treatment failure, they decrease the length of hospital stay, they improve the FEV1 up to 5 days, and there is no benefit beyond 2 weeks of use. So the oral corticosteroids or systemic use of corticosteroids need not be prolonged beyond 5 to 7 days. One should start early for maximum benefit, and routinely one gives prednisolone 30 milligram per day for 7 to 14 days. However, the variations are there depending on the patient's status and other factors. Antibiotics are required only when there is a presence of infection, for example, purulent sputum and pneumonia. There is more benefit in more severe exacerbations. Initial empirical treatment options are the aminopenicillins, macrolides, fluoroquinolones, and tetracyclines, etc. 5 to 10 days therapy with antibiotics is given. In this country, we always recommend that do not use fluoroquinolones as the first choice without excluding tuberculosis, because we all know that fluoroquinolone is a good anti-tubercle drug, so it can mask the diagnosis of tuberculosis. Non-invasive ventilation may be required in COPD, in acute exacerbations, if patient is not responding to the supportive therapy and controlled oxygen supplementation, as said earlier. But one should initiate as early as possible if the respiratory rate is more than 24 and there is hypercapnia with acidosis. These are the classical indications for non-invasive ventilation. There is no benefit in milder exacerbations of NIV. Routine domiciliary use is also not recommended. It should be used only when there is a definitive indication. It may be useful in patients on long-term oxygen therapy with persistent and pronounced daytime hypercapnia. You can see this forest graph. You can see here and most of the studies which have been done on domiciliary ventilation, the risk kind of the NPPV or NIV, the non-invasive ventilation, they favor the administration of NIV for acute exacerbation, especially the severe exacerbations you see. Mechanical ventilations is routinely not required. It is given only when NIV is contraindicated or patient has not responded well to NIV or the patient does not tolerate NIV, then perhaps we need to give mechanical ventilation with intubation. It supports gas exchange and the disease modifying therapies reverse the cause of deterioration. One should, the previous therapeutic nihilism regarding mechanical ventilation and COPD is largely unfounded. So it has been found that a lot of these patients can be taken out of the exacerbations or acute problem with a short period of mechanical ventilation. This is the chart which one follows normally, the algorithm for exacerbations of COPD, kind of when there is a contraindication for non-invasive ventilation, then one should intubate these patients and then subsequently wean. On the other hand, if there is no contraindication to the NIV, then NIV with monitoring is done. One follows the improvements in pH, PaCO2, clinical status, etc. And if there is improvement, then one continues with the NIV and then subsequently wean, depending upon the clinical and other parameters. On the other hand, if there is no improvement with NIV, then one has to intubate and mechanical ventilation is done and give a 2-hour tube trial. If it is successful, afterwards then weaning is done. Otherwise, if it is failure, then of course one has to continue. Briefly about the management of complications of COPD. The more common complications of COPD, the most common is the chronic cor pulmonale and respiratory failure. The rupture of bullae and blebs can occur, causing pneumothorax, pneumomediastinum, and subcutaneous emphysema, etc. Polycythemia is common. Then increased coagulation problems like in situ thrombosis or pulmonary thromboembolism has been also reported and common in COPD. Hyperuricemia can occur, and of course depression is an important term. Here you can see this is a patient with gross cor pulmonale, the pulmonary arterial hypertension, cardiomegaly is there, and the pathophysiology of this type of condition is there are a lot of factors. I will not go into those details, but multiple factors play their part in the pathophysiology of such a condition. And the treatment for this type of patient would be treatment of COPD as usual, long-term oxygen therapy, and importantly, because there is fluid retention, so there is role of diuretics in these patients. The CO2 levels one has to maintain at a reasonable level. If there is digoxin, atrial fibrillation, then one can use digoxin in low doses and vasodilators, but they may be hazardous as well, especially in lower systemic and pulmonary blood pressure, because they would further problem. You see, bullous emphysema is another important condition. Here you can see on the left hand side is a big bulla, almost the entire lung is replaced, the right lung replaced. On the other hand, the right side X-ray shows the pneumothorax on the left side, you see. And similarly, complications like pneumomediastinum can happen. So you can see all around the heart there is air in this patient. So one has to manage these complications accordingly. Then of course the systemic manifestation of COPD or systemic complications can happen, like general are very common: wasting, weight loss, nutrition abnormalities, anemia. Then musculoskeletal problems are there, like musculoskeletal muscle dysfunction, osteoporosis, reduced exercise tolerance, sometimes even spontaneous fractures can happen. Cardiovascular are common, like pulmonary vascular disease, ischemic heart disease, acute events and cardiac failure, stroke, endocrinal like diabetes, metabolic syndrome, etc. So multiple types, all kinds of systemic complications are known to happen in COPD. COPD and cardiovascular disease is in particular important because many of these patients in fact are now known that they die because of cardiovascular disease rather than because of respiratory failure. It has been also seen that it is a powerful independent risk factor for cardiovascular mortality and mortality. So smoking cessation, which is responsible for both these conditions, is more important. Beta blockers, there had been a previous fear that they may aggravate as bronchoconstriction, in patients of COPD, although they may be required for ischemic heart disease, especially cardiac arrhythmias and so on. I think it is important here to say that they are quite safe if they are required. So in COPD, there is no real contraindication to use the beta blockers. The non-pharmacological therapy is also important, is as much as important as pharmacotherapy. For all stages, patient education, smoking cessation, pulmonary rehabilitation, immunization and nutrition. These are very important non-pharmacological modes of treatment. In the late stages of COPD, it is important, for example, the long-term oxygen therapy, the surgical options, and the NIV, domiciliary NIV. These are other important non-pharmacological treatments. Pulmonary rehabilitation is a multidisciplinary approach to rehabilitate these patients and improve their quality of life as much as possible, and it covers a wide range of non-pulmonary problems that may be adequately addressed by medical therapy for COPD, like exercise training. It is a structured exercise training, so that patient is given a structured kind of OPD training, for a few weeks, and then advised to continue regularly at home. Patient education, nutritional counseling is important, then regular follow-up. Is important. What is patient education? In particular, patient should be explained the nature and prognosis of disease, avoidance of potential risk factors, the treatment of and compliance, the technique to take inhaled drugs, recognition of disease exacerbations, strategies to minimize dyspnea, and specific facets, especially the smoking cessation and nutrition. So that is some of the most important components of comprehensive treatment of COPD. Acute smoking is perhaps the most important step of all forms of treatment. If a patient is smoking, because as long as patient keeps on smoking, all other treatments are practically futile. It is the only intervention is associated with a survival benefit. That is another important. The second being domiciliary oxygen. So most important, smoking cessation is very relatively easy and kind of non-costly, you see. Decline in pulmonary function slows down after discontinuing tobacco smoking. You see. There are also drugs available nowadays which can help smoking cessation, but they are useful only when counseling alone is not sufficient to help patients. There are two types of smoking cessation. Like nicotine replacement products. However, they alone are not useful. One has to use other replacement or you can say the other drugs like bupropion, or more importantly is varenicline or nortriptyline, which is now available. Immunization is also required in these patients. Influenza vaccine in particular, live inactivated viruses of currently prevalent strains are administered against influenza, and it is a annual vaccine. So it has been shown that it prevents the infective exacerbations and complications. Then there are pneumococcal vaccines like polyvalent and conjugate pneumococcal vaccine, which are also recommended in these patients. Nutrition, because weight loss is a very important issue, so I think nutritional therapy is quite important in these patients. Oxygen therapy at home, the long-term continuous therapy is given, and that also improves the survival, you see. And these are the classical trials with which you would be familiar, which were done in 50s and 60s, that they show that the domiciliary long-term oxygen trials at home, the longer you give, the more helpful they are, you see. The domiciliary therapy improves survival, reduces hospitalization, increases exercise tolerance, reduces the dyspnea, pulmonary vascular resistance, pulmonary hypertension, reverses secondary polycythemia, and increase lean body weight, you see. Lastly, as far as the surgery for COPD is concerned, that is done for specific indications like bullectomy if there is a presence of large bulla. Lung volume reduction surgery had been done, and popular that to make the lung more compliant, you see, although it may not improve survival in the long run. Lung transplantation perhaps is the only method which is available in severe forms of COPD, when practically it's a kind of disabling emphysema which is not responsive to any drug and other forms of therapy. So in summary, I would say that COPD is a common systemic inflammatory disorder and not just a disease of the lungs. It is a systemic problem. It is also a powerful independent risk factor for cardiovascular morbidity and mortality. Disease progression can be slowed and quality of life improved if appropriately managed with the comprehensive plan, which includes maintenance therapy, pharmacotherapy, non-pharmacological therapy for prevention of exacerbations and pulmonary rehabilitation. Besides pharmacotherapy, smoking cessation is the most important component of management. Domiciliary long-term oxygen therapy also prolongs survival and improves quality of life in these patients. Well, thank you very much for your patience.